PHA 114, Intro to Pharmacology, Chapter 3, Part 2. Welcome back. So now I'm going to go through the steps of the drug cycle. This is actually called pharmacokinetics. So what is the process as the drug is going through the body? And how does it process through? So when we talk about pharmacokinetics, we use the an acronym ADME. It will depend on what route. Again, we're not going to go into a lot of detail, but it is important that you understand that everybody's going to work a little differently. So when we talk about these pharmacokinetic parameters or these steps, we have absorption. Now, before a drug can be absorbed into our body, it has to be administered. So if you don't take it, it's not going to happen. If you have a headache, you can't just put a Tylenol capsule on your forehead and it makes you better. It's not magic. You actually have to swallow the Tylenol, and then it will absorb into your body, and then it'll go and activate receptors and help to relieve the pain. Distribution is an important concept. So I'm gonna go here with this. So it's given the stomach. It's showing some absorption in the stomach. Very few drugs are absorbed in the stomach. Most of your drugs are absorbed in the small intestine. But when they are absorbed, they get absorbed into your bloodstream. Your bloodstream is the distribution zone. So it's going to carry it to the body where it can connect to that receptor. Now, one of the stops that it makes is in the liver, which is where we have metabolism. The term metabolism means change. So it's a metabolic, it's a biotransformation. It's a change in the body. It's going to change the drug. It can change it from an inactive form to the way that a drug that your body can use, or it will start to break down the drug so that it can then be eliminated. So through an oral administration, your stomach and your liver can change the amount of drug that's available to the body. And then excretion, most of our drugs are actually going to be excreted out through our kidneys, from the bloodstream. Some will only stay in the GI system, and they'll actually be eliminated out through with your feces. But if it gets absorbed into the bloodstream, it's going through the kidneys. So this is just a simple image. This is from your textbook, but I'm just going to take a minute to go in a little bit more. Again, I do have videos that are going to follow that will walk you through some of this stuff, so maybe it'll help give you a better visual. So absorption, again, it's the first step. For absorption to occur, it will depend on the route of administration. So if you're taking it orally, it's probably going to absorb in your small intestine. If it's a parenteral drug, if it absorbs systemically through the skin, or it's given as an injection, you're not going through your stomach or your intestines. It's going to get to your bloodstream quicker. So that has a real key to how fast a drug may work. Now, when we're talking about oral administration, once you swallow that tablet, it's not like automatic that your headache goes away. If you put the tablet on your tongue and you leave it there, you're going to feel it break down. That's disintegrate. Now, it'll leave a bad taste in your mouth, so we swallow it quickly, right? Then it has to dissolve. So it gets to your stomach and it mixes with fluids in your stomach, including acid, and it dissolves. Now, once it's all dissolved, it can be absorbed. So there are steps that need to occur. Some drugs will absorb more quickly than others. If it's already in a liquid form, it doesn't have to disintegrate. And it may not even need to, it's going to dissolve. It's still going to change with the liquids so that your body can absorb it, but we're going to skip that disintegrate step. Go back to a headache, right? You have a headache. If you take a Tylenol caplet, a tablet shaped like a capsule, it's probably not going to work as fast as if you used Goody's powder, right? Because it's already kind of broken down. So you've got surface area, so when it dissolves much more quickly because it's already disintegrated. Like I said, with oral, it's mostly going to absorb in your small intestine. Now the next step is considered to be distribution. Again, if it's by administration of directly into your bloodstream, you don't need to absorb it. It's been injected straight through. So IV doesn't have absorption. Everything else has to be absorbed, but an IV administration does not have absorption. But drugs get distributed, so they're going to flow through your bloodstream, and they're going to get distributed throughout your body via the circulatory system. Some of that drug is going to bind up with other compounds and chemicals that are in your body that can include plasma proteins. If it binds with that, it's not going to be available to use on a receptor. So the drug, it's going to take up some of the drug. There are other concepts that are going to impact the way that the body's availability of this distribution. Blood flow. If you've got poor blood flow, it's not maybe going to get where it needs to go. Or we also talk about affinity to receptors. If it really likes it, it's going to bind more quickly. If another drug is already present that it likes even better, it's going to have a harder time connecting and causing that pharmacological effect. Now, how much of the drug that's not bound, that could connect with a receptor, that's available in the body, is known as bioavailability. So we already know that we're going to lose some when we have digestive enzymes. We're going to lose some because it's going to bind to those plasma proteins. Some are going to be clingier to that than others. So they already know. If somebody needs a dose of, let's say, 10 milligrams to have an effect, of bioavailable 10 milligrams, and they're taking it orally, they might take 15 milligrams because we know we're going to lose some of it. It's not going to have that same effect. Now, a couple of things in consideration of distribution. There are some places in the body where we really kind of don't want drug to go because it can have some impacts on the body. So the blood-brain barrier. So we do have a barrier that protects the brain and the spinal cord. Oh, I guess I had those connected together. I know it's not a real clear picture, but it's going to create a network that only certain drugs are going to be able to get through. So if you think of it like a net, and there's little spaces in between. If you kind of thread your fingers together real tightly, you might not see the light, but there's going to be little openings, because if you try to hold water, some of it's going to drip out. But when we have swelling in the blood-brain barrier, maybe there's meningitis, maybe there's been an injury and the net is ripped. Things that wouldn't be normally getting through now can get through. With meningitis, when we get that inflammation, if the blood-brain barrier is closed up, some antibiotics aren't going to get through. But if we've got swelling, we want those antibiotics to get through. So it's good that we have those kind of spaces for it to fit through. Placental barrier is another thing to be considered with. Certain things will cross the placental barrier and can be passed from the mom to the baby. Examples. So if a woman has gestational diabetes, maybe they have type 2 diabetes and then they get pregnant, their medications that they would be taking orally could be harmful to the baby. So they would get switched to insulin because that's not going to be harmful to the baby. Maybe their Avandia would pass through that placental barrier and cause some problems. Now, metabolism, this is where, like I said, the term metabolism means to change. It's also known as biotransformation. It could be a drug needs to change into an active form, or maybe it's going to start breaking the drug down. So again, the video that I have beyond this lecture, it's got some good imagery to kind of clue you in on that. But where metabolism takes place is in your liver. So I've got a picture of the liver here. And with the liver, we have something with oral medications that are called first pass effect. This is not your injectables. They will still undergo metabolism, but they're probably going to hit their site of action first. When we have an orally administered drug that goes through the stomach, it gets absorbed, and the majority is going to go into the liver. So it's going to go from the stomach, where we lose some of the drug due to the hydrochloric acid, and then it's going to go into the liver, and some of it's going to get changed out. Then it's going to start going around the building, around the body. Maybe a patient has pain and they're given morphine. Now, if they're given a morphine tablet, maybe they get 30 milligrams. But if we're giving it as an injection, maybe they only get 2. There can be a difference in the dose because how much is actually going to be available to the body. Again, that process with the oral administration is called first pass effect. It decreases the bioavailability of the drug that has been ingested. The last step is the E, excretion, clearance, elimination. How does the drug leave the body? If it doesn't leave the body, it can continue to travel around and continue to cause toxicity. So it needs to be excreted. It's usually considered waste. The metabolites, those breakdowns that came out of the liver, get washed out of the body. Now, the most common route of elimination is going to be through the kidneys. The liver will change a drug into a water-soluble drug, and when the circulatory system reaches the kidneys, it can be filtered out and eliminated. But there are other routes of elimination. Through the lungs, through saliva, and through tears, as well as sweat. So what do these things have in common? Water. So when you are a kid and you breathe on a window, right, you get that condensation you can write on the window. So sometimes we'll smell it on a patient's breath, a drug, or in their saliva. Maybe they get a metal taste in their mouth or an off taste in their mouth. Tears and sweat. Certain drugs can actually cause staining of contacts or staining of clothing because some of the metabolites are excreted through those means. But again, the number one most common, and then of course we also have feces, but those are things that haven't been absorbed. Those are things that go straight through your GI system. Okay, so when we administer drugs, there are things that we want to keep in mind. These are known as the 7 rights of drug administration. And if you're always thinking about these 7 rights, then we're going to keep our patients safer. This helps avoid errors. So, right drug. Are we picking the right drug? And that includes, do we have the tablet or the well, that comes for the form. Right strength. Okay, do we need 5 milligrams or do we need 10 milligrams? Is it the right form? Is it the tablet? Is it the capsule? Is it the extended release? Is it injectable? Was it supposed to be given IM, but they injected it intravenously or vice versa? So we need to make sure that we're providing the drug in the right form. Did it go through the right route? Was it supposed to be taken orally? So form and route often are pretty closely related. What time? When was it supposed to be given? Is it supposed to be given with food? Is it supposed to be given in the morning on an empty stomach? Is it supposed to be taken at bedtime? Is it supposed to be taken every 12 hours? Is it only once a day? A lot of information. And are we giving it to the right patient? So in the hospital, we can use those barcode wrist bracelets for identifying our patient. And the last thing, right documentation. Because we do use technology and we are using barcoding, usually the EHR, the electronic health record, is connected. So as you administer the medication, it gets recorded. In the old days, it was done manually. And then we had to make sure that it was billed properly. In medicine, if it's not documented, it didn't happen. That's also a safety thing, right? If we don't record that the patient received the medication, after shift change, another nurse may come and give them their medicine. Now they have an overdose. So documentation is a key component to those 7 rights of administration. The next thing your book talks about is drug recalls. So occasionally the FDA or a manufacturer may ask for a recall. It is the responsibility of a drug company to notify providers, hospitals, pharmacies, and even the news and consumers of drug recalls. Once notified, it is then the responsibility of the provider, the hospital, the pharmacy, or the consumer to dispose of the recalled lots of drugs. We hear about recalls on food in the news and things like that, sometimes on drugs. Usually the pharmacy will get an update, and then they will follow all of the procedures according to their policy and procedure on how to proceed. Some recalls have no outcome. All it is, get rid of it. Some could be very harmful to patients. So some of the different reasons for recalls. The first one, there isn't the right amount of active ingredient in the drug itself. So it's not going to work right. Or maybe there's too much. You know, if there's not enough, it's not going to work right. If there's too much, it's an overdose. So it's not the correct amount. The drug itself doesn't stay stable for as long as it's supposed to. So it becomes not usable before its expiration date. The label may not be complete, or there could be inaccurate information. Maybe it didn't list an ingredient. Maybe it doesn't have the lot number or the expiration date on it. There could be a problem in the manufacturing where the product itself got contaminated. There's some foreign particle or another drug in that container that's not supposed to be there. And then a lot of recalls are due to adverse events, illness or death that could result from the medication. That's going to be a much more serious recall, and sometimes we don't know about that until patients are actually hospitalized. Now, because not all long-term effects of drugs can be known, remember in Chapter 2 when I talked about the post-marketing surveillance, and I was talking about ranitidine, we had a recall on that, and they actually pulled the whole drug from the market because of the bad effects of it. So there's a lot of different reasons for a recall. Now, when doing a drug recall, there's two pieces. If it's because there's something wrong with maybe that batch of that drug, we need to have that lot number and the expiration date to make sure we pull the right ones from the shelf. Because it may not be the whole drug itself, it may just be a batch that was made that had the problem. Staying safe with our medications and the medication handling, we want to know about storage and disposal of our drugs. So medicine cabinets in the bathroom, usually the place where we keep the drugs, but heat and moisture can break down the active drugs. So they actually should be stored in a cool environment, generally in a locked box to protect it from kids. At home, unused drugs should be disposed of properly, not just flushed down the toilet, because that can contaminate the groundwater. So it's important to review where proper disposal. So again, unfortunately, I got a fuzzy picture here, but there is, the FDA site has certain drugs. It will tell you which ones are safe to flush down the toilet. It's a short list. Otherwise, don't do that. Don't put them down the sink. Don't flush them down the toilet. There are often at pharmacies a disposal bin. So you can bring them to a pharmacy. They'll dispose of them. Pharmacies never reuse medications that are given to them from patients. Once it crosses that counter to the patient, if it comes back across that counter, it's never, ever, ever going to be reused again. It's going to be disposed of. We also need to know, does the drug need to be neutralized? Is it a hazardous drug? Is it something that could be a challenge, not only like hormones and things like that, but things we don't want in the groundwater, antibiotics and things like that. We often can neutralize using charcoal. I know the book talks a little bit about crushing them up and putting them in coffee grounds and kitty litter. I'm going to be honest and say that's not a good way to do it. This is kind of one of my little soapbox things. I'm really into making sure medications are disposed of properly to protect the environment. We got enough garbage that can cause problems that get into our groundwater. We don't need to add to that. Charcoal is pretty much the only thing that's going to deactivate. People who have medications, they can purchase bags or even kind of like a gallon container that has something in it, and it might already be liquid, or you might add water to it to activate it. You ground up your tablets and you throw them in there, and it's all good. The other thing is proper disposal of syringes and needles. So this image over here on the right is called a sharps container. We don't want needles and syringes, people getting stuck. So we don't want to throw those in a garbage can. A sharps container is going to be a hard-sided plastic container bin that can then be closed and not reopened. So somebody can't go in and go digging for needles or for medicine. So that's another way to properly dispose of those sharps and things like that. All right, so that was a quick on the second part. Again, after you answer your questions, go ahead and check out those videos. I think that you'll find them helpful in understanding the concepts from chapter 3.